So the first part is, of course, the unmet need. We know that patients that have DOAC-related hemorrhages or direct-acting oral anticoagulant-related hemorrhages, whether they be factor 2 inhibitors or direct thrombin inhibitors like dabigatran, or factor 10A inhibitors, the oral ones being Apixaban, Edoxaban, and Rivaroxaban, are at high risk of hematoma expansion. So although there is some data to suggest that their initial ICH volumes and initial severity of stroke quantified by the NIH stroke scale is less at presentation relative to the more traditional anticoagulant vitamin K antagonist, their proportion of hematoma expansion and the proportion leading to mortality are essentially the same as vitamin K antagonists. And thus there's a major unmet need to develop and prove efficacious hemostatic treatments that can reduce hematoma growth and improve outcomes in these patients. For direct factor 10A inhibitors in various parts of the world, including Europe and the United States, there is a direct inhibitor or reversal agent, rather, available. And that reversal agent is Andexanet alfa. It essentially serves as a decoy molecule that binds the factor 10A inhibitor, allowing the endogenous factor 10A to essentially get to engage in the hemostatic cascade. The evidence that has brought this drug to market was a single-arm trial, and that was the ANNEXA-4 study. And in this trial, actually, a large proportion were patients with ICH, so more relevant to a stroke population for stroke neurologists than, for instance, the Idrisuzumab trial that preceded the approval of Idrisuzumab for the reversal of dabigatran. As far as indirect comparisons go with historical cohorts, the degree of hemostatic efficacy was much greater than what you would expect in this patient population. Having said that, because there was no control arm, we can't say that that was truly a treatment effect and not due to selection of this population being a healthier population, or maybe one that was enrolled at a later time frame where their natural history was one where they weren't going to expand as much as some of the historical cohorts we've seen. In addition, there was roughly a 10% thrombotic risk or thrombotic event rate in this cohort. Again, because there's no control arm, we're unable to say, based on the ANNEXA-4 study, whether this is the natural history of a high-risk frail population that was being anticoagulated for a reason, because they have endogenous thrombotic potential, or whether or not factor Andexanet alpha itself can promote thrombosis or that has thrombogenic potential. And there is a biological pathway for the latter, in that there has been studies demonstrating that Andexanet alpha can inhibit tissue factor pathway inhibitor. And if you inhibit TFPI, you can actually result in a prothrombotic state. So there is a biological pathway for this to be a true effect of the treatment, but we simply just don't know due to the absence of a comparator. Now, based on these results, the approval of the EU regulatory bodies and the FDA is that the approval is contingent on the completion of a phase III trial. And although it's been approved in the interim, a phase III trial needs to be conducted before full approval. On the basis of this uncertainty and observational data demonstrating that there may be some benefit from the use of alternative hemostatic therapies, such as prothrombin complex concentrate, there is uncertainty at present in the community regarding whether the increased cost of Andexanet alpha is offset by a greater efficacy relative to other potential hemostatic treatments in patients who present with factor 10A inhibitor-associated ICH. The cost of Andexanet alpha has reduced substantially, and that has helped in some regard. I'm not sure if your viewers are aware, but the company that was producing Andexanet alpha was purchased by AstraZeneca Global, and they, of course, their capacity to produce the drug has led to reductions in cost. So that has helped in some regard, but the uncertainty remains. And our most guidelines at present in the United States and Europe indicate that although patients that have factor Xa associated ICH should be reversed with Andexanet alpha, there is ongoing uncertainty. And particularly in the EU guidelines or ESOC guidelines, they encourage enrollment into ongoing randomized trials to address this uncertainty and actually have a placebo or a controlled trial where we can compare the effects of Andexanet alpha versus the usual standard of care. So that trial was conducted. And that is the ANNEXA-I trial that we're leading out of the PHRI, with the PI being Stuart Connolly, my colleague Stuart Connolly. That study, interestingly, since the completion of ESOC, was terminated because the interim analysis, a pre-specified interim analysis, demonstrated overwhelming efficacy or hemostatic efficacy with Andexanet alpha versus usual standard of care. So we're definitely now getting much closer to having a definitive result. That is beyond that headline that I just mentioned. The study results have yet to be published or announced publicly, and of course, they're still in the process of study. We're still in the process of study closeout and completing adjudication of all events so that we can present the initial results in these 450 participants that were analyzed at the interim analysis. However, I think if there was doubt previously regarding the use of Andexanet alpha in this patient population, at the very least, based on the current publicly available data, we can say it results in greater hemostatic efficacy, and there is an advantage there. When it comes to the thrombotic events, that was also part of the concern after the ANNEXA-4 study. That data will also need to be factored at some point, but that data is not publicly available right now. But that will be part of course, the main trial result publications and presentation at an upcoming international conference.